I think I know ROP a little bit, so I'll be talking about anti-VEGFs in ROP, which is catching up very fast and still remains a controversial topic, and we are yet to come out with final guidelines about its use. So before we go to anti-VEGF in ROP, let's quickly look at ROP itself. It was described by Terry in 1940s, called as retrolental fibroplasia. It was in decline in 1990s till 1990s, but after that, after improvement of neonatal services, the extremely low birth weight babies can be saved, and hence the incidence is going up again. The incidence seems to be higher in Indian babies, and hence this talk is very relevant to us. Coming to embryology, the hyaloid artery develops at 6 weeks, and vascular precursors grow across the retinal surface by 16 weeks. The nasal periphery, the vascularization reaches nasal periphery by 32 weeks and temporal periphery by 36 to 40 weeks. The remodeling of capillary meshwork happens up to 2 to 3 months after the birth. So the earlier the baby is born, the less mature vascularization we are going to end up with. So there is a schematic showing at various points of time as it grows. Coming to pathophysiology, ROP is a biphasic disease. It is a progressing vasculature which is accompanied by astrocytes which sense oxygen level and secrete VEGF in response to hypoxia. VEGF, however, is dependent of insulin-like growth factor which is transported across the placenta. So the phase 1 ischemic phase with premature birth, IGF levels drop. Hyperoxia is also caused ex utero, and because of these two factors there is a drop in VEGF also, and normal vascular growth ceases. Up to 4 weeks the choroidal capillaries can supplement the retina, which is thin, but after that the retina becomes metabolically active, and hence there is upregulation of VEGF by ischemic retina. There is also gradual increase in IGF-1 levels, and around 34 weeks of gestation, the phase 2, that is vaso-proliferative phase, neovascularization phase is triggered. So this is a cartoon showing these phases as they develop. So risk factors for development of ROP, as we all know, is gestational age, especially if it is less than 28 weeks, birth weight less than 2,000 grams, as been described by various studies in India, in Indian infants. Oxygen level, 85 to 92% is thought to be more commonly associated. Other factors like sepsis, blood transfusions, anemia, etc. are again higher risk factors. Coming to screening protocols, the babies which are less than 1500 grams with gestational age of less than 28 weeks and unstable clinical course, first examination done at 4 to 8 weeks with indirect ophthalmoscopy and dilated pupils in NICU, and it can be done without any anesthesia by wrapping the baby properly. RETCAM, there is a RETCAM which is there, and Indian camera has also come, which is used extensively, including at Dr. Unnikurishnan's hospital, where it can be an optometrist can be trained to screen the babies, and by teleophthalmology the babies can be screened, and those which require treatment can be brought from remote places to the base hospital and treated. So coming to classification, it depends on the location of the disease, extent of involvement, stage of vascular proliferation, and type of ROP. So these are the zones, as we all know: zone 1, zone 2, and zone 3. ROP stages: stage 1 is demarcation line, 2 is ridge, 3 is extraretinal proliferation, 4 is partial retinal, this is stage 3. Stage 4 is partial retinal detachment. In 4A there is macula is spared, 4B macula is involved, stage 5 is total retinal detachment. This is a small animation showing development of ROP as it progresses. There is first the demarcation line, ridge develops, vascularization, and then as it contracts, as the vascularization contracts, it leads to retinal detachment. So plus disease is where there is engorged venules and tortuosity of arterioles, and iris vascular engorgement and rigidity of pupils is there, vitreous haze is seen. Threshold ROP as described by IC070 study, where there is stage 3 with plus disease, zone 1 or zone 2, having 5 contiguous or 8 cumulative clock hours. There was a 50% risk of blindness. Pre-threshold ROP was described by ET-ROP study, that is early treatment of ROP, where zone 2 with stage 3, which is less than 5 contiguous or 8 non-contiguous clock hours, zone 2 with stage 3 without plus disease, and zone 1 with stage 3 and with or without plus disease, we have to treat these babies. So aggressive posterior ROP, this is a very severe form of ROP and which leads to very fast progression through advanced stages, and it may bypass early stages and can quickly reach total retinal detachment. Plus disease, which is out of proportion to the lack of to the severity of disease, is is what is AP-ROP, and it needs immediate treatment. Now all this is how the AP-ROP would look. We can see large capillary vascular loops. And treatment options, laser photocoagulation, cryotherapy is more or less not done. Laser photocoagulation remains the gold standard or standard of care as of now, and anti-VEGF injections are the new treatment modality which is coming in, and scleral buckling and vitrectomy are required in advanced stages. So what is good response whenever there is resolution of disease, resolution of ridge, progression of normal vascularization beyond the demarcation line, and clearance of media. While in poor response, if the disease still progresses beyond stage 3 to stage 4, that requires surgery, it is poor response. This is how usually we do laser. It is done in ICU. It can be done quite safely without giving any anesthesia, though there are some centers which insist on giving general anesthesia for this. We have to put in as many burns as possible, up to 2.5 to 3,000 burns are required usually, which are done in a very contiguous manner, unlike panretinal photocoagulation, where we are supposed to leave areas in between. So coming to laser photocoagulation is indirect delivery. We can treat right up to posterior, and or we can space the treatments. We can do it in multiple sessions if required. The advantages is that it's usually a one-time therapy, and finite follow-up is usually that is sufficient in more than 90% of the patients. And long-term effects, it's supposed to protect the eyes from retinal detachment in future. While the disadvantages are, there is a learning curve to doing lasers. The laser equipment can be costly. If there are skip areas, if the laser is not done properly, it can lead to higher recurrence, and there is a higher chance of myopia and constriction of peripheral visual fields. Coming to ROP, all these things were required because we have to put things in perspective about the use of anti-VEGF in ROP. So this is how the injection is done. It's done 1 millimeter from the limbus, and with 30 gauge needle. The needle is done under topical anesthesia. Needle is directed more posteriorly so as to avoid lens trauma. So the advantages of this are ease of use. There is rapid response. In long term, the myopic shift is found to be less, and the visual fields are thought to be better as compared to babies who are treated with laser. So these are, as we all know, these are the molecules that is pigaptanib, which is thought to be safer because it is a selective VEGF165 blocker, and thought to be safer as far as the neurodevelopment of these babies is concerned. Bevacizumab, Avastin is most commonly used, and most of the studies involve intravitreal injection of bevacizumab. Ranibizumab, it's thought to be little safer as the half-life in the vitreous cavity and in the systemic circulation is less, and it is rapidly eliminated from bloodstream. Aflibercept, there are not too many studies, but now it's being used more commonly. BEAT ROP study was the first trial which compared the effect of anti-VEGF drugs, that is bevacizumab versus laser in ROP, that is standard of care. It stands for bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. This was a prospective controlled randomized stratified multicenter trial to assess intravitreal bevacizumab monotherapy for zone 1 and zone 2 posterior stage 3 disease with plus disease in ROP. The infants were randomly assigned to receive IV-B, which was given in 0.625 milligrams, and primary ocular outcome was recurrence of retinopathy of prematurity in one or both eyes requiring retreatment before 54 weeks of PMA. The recurrence rate in zone 1 disease in this study was found to be much higher in laser as compared to Avastin, while there was no statistically significant difference when the disease was present in zone 2. So they concluded the intravitreal IV-B monotherapy compared to conventional laser therapy in infants with stage 3 plus retinopathy or ROP is beneficial in zone 1 disease, and development of peripheral retinal vessels continues after treatment with intravitreal bevacizumab, but conventional laser therapy led to permanent destruction of peripheral retina. This trial was thought to be too small to assess the systemic safety of this particular injection. Coming to criticism, this study has been criticized by some authors, which says that they looked at a small subtype of type 1 ROP. Can I continue for a few minutes? Yeah. The primary outcome was not masked. They assessed assessment was till the early age, that is only till 54 weeks. By non-impartial observers, and visual outcomes were not reported, and important adverse outcomes were not assessed thoroughly. The stage 3+ disease, as ranibizumab is thought to be more safe, but as Wong et al. Have described, there is a higher chance of recurrence with ranibizumab. The disadvantages of anti-VEGF, there is delayed vascularization. The avascular retina can be seen much later in the disease. There is a recurrence. Chances of recurrence are higher, and recurrence can happen very late, and it is often difficult to examine the babies because they become larger in size, and it's difficult. We might miss a recurrence if it is done, if it is not done under examination under anesthesia. The long-term effects are unknown, and uncertainties about drug dose, other side effects like endophthalmitis and cataract. Again, coming to the timing, when do we inject this disease? It's thought to be, appropriate timing is thought to be 31 to 35 weeks, because if we treat much earlier, we are going to stop the vascularization late, or if it is treated too late, it can worsen the retinal detachment, and that the proliferative tissue which develops is thought to be much difficult to operate. Prior to vitrectomy remains a controversial topic. Some surgeons have advised by giving about giving Avastin before surgery for ROP, but it should be done within 1 week, while other surgeons are against use of this. So if it has to, if the disease is very vascular, and if you are planning to give it prior to vitrectomy, it has to be done within 1 week. The dose, again, the BEAT ROP trial has given dose of 0.625 milligrams. However, even lower dose of IVB, there is 0.375 milligram has been shown to cause regression in ROP. So coming to recurrence, it is common. It happens in delayed recurrence. In BEAT ROP trial, the recurrence in laser happened at 6.5 weeks, while in IVB it happened up to 19 weeks. Hu et al. Have shown that the recurrence can happen almost up to 50 weeks. The pattern of recurrence is different than what happens in laser alone. The recurrence can happen at site of original ridge also, instead of vascular and avascular retina. And we have to have frequent follow-ups, and we should not be missing this kind of treatment. Complications are ocular complications, which we can avoid by giving proper method of injecting, and systemic complications, it is thought to be more or less safe by various trials. However, still there are some studies which say that neurodevelopment can be affected in these babies. So coming to medical legal issues, one thing we have to understand is that all anti-VEGFs are off the label as far as ROP is concerned, be it bevacizumab, be it ranibizumab, be it aflibercept. All of these drugs are off label, and so properly written, documented, consent has to be taken, every visit has to be correctly has to be properly documented. So in conclusion, it's an effective treatment modality in difficult cases. It's a laser therapy, as of now still remains gold standard till we know when to inject, how much to inject, and if we decide to inject, the prolonged follow-up is necessary. So thank you for your kind attention.